Copyright Stanford University, all rights reserved.
It's my pleasure to be back. I know a number of you and see familiar faces, and see familiar faces from a visit a year and a half ago. So if there's some overlap with what I present today, I apologize, but I tried to reframe some things and cover some new material here. What I'm planning to talk about here is UPPP Outcomes, and I frame it in the context of outcomes research because I think it presents a nice model for how we might approach outcomes research in the surgical field. I'm coming from Seattle. That's how it looks like every day, right, Sam? Disclosures, no industry disclosures. My research funding is from NIH and foundations. I am a surgeon. I present that because when I'm in mixed audiences, that might highlight potential biases, but hopefully also some expertise. But I also wish to highlight that I'm a sleep medicine physician, so hopefully I can bring balance to the discussions on sleep apnea care. I'm focusing on adult sleep apnea, so apologies to Peter and other pediatric otolaryngologists. Pediatric sleep apnea, while has significant overlap with adult sleep apnea, is a different entity, I think, and probably warrants a different approach. And then this presentation is going to be very self-centered because I'm going to present my data since I'm here giving a presentation in looking at a position, and I don't want to leave people with the impression that I think these are the only data that are out there. There's a lot of people who've done work that is right along the same lines. So I'm highlighting mine deliberately just to let you know some of the things I've done. Long list of acknowledgements of funding, collaborators, and research personnel. And here's the outline of the content I'm going to try to cover. First, I just want to talk about sleep apnea, obstructive sleep apnea, and uvulopalatal pharyngoplasty. First, quickly, some definitions, and then surgical descriptions. This is a surgical audience, so I know that's one way to get people's attention. I want to tell you a bit about what UPPP is to me, because it's more than what it used to be, and so I want to highlight that. Then the second half will be on UPPP outcomes. I want to pose some key questions about UPPP, lay out an outcomes research structure to present these types of data, and then go through a number of outcome studies within that structure. Now, I want to point out right off the bat, UPPP does not define sleep surgery. In fact, it's a small piece of sleep surgery, and it's rare that I do isolated UPPP. So why am I focusing on that for a presentation here? And the reason why is because that's where we have the most data, by far. And so for a research presentation, I chose to focus on that subset of sleep surgery. So obstructive sleep apnea, just to bring everybody up to speed in case there's non-clinicians here or others not familiar, here's a working definition of obstructive sleep apnea syndrome. Symptomatic, recurrent upper airway obstructions during sleep. Every single word in that definition is critical to the definition, but it's as simple as that, recurrent chokings that create symptoms. There's significant consequences with daily morbidity in a variety of forms, as well as long-term morbidity and mortality. So that's my summary of the topic of obstructive sleep apnea in one slide and 2 bullets. Not bad, huh? Within obstructive sleep apnea, one of the treatments is surgical treatments, and uvulopalatal pharyngoplasty is probably the most commonly applied surgical treatment, surgical procedure, henceforth abbreviated UPPP. And here's a working definition for uvulopalatal pharyngoplasty. It's a reconstructive procedure of the palate and or pharynx to open or stabilize the upper pharyngeal airway. And I wish to point out that in this working definition, it does not include isolated stiffening procedures which are designed for snoring as opposed to obstructive sleep apnea. How do I go about applying UPPP in the treatment of sleep apnea? Here are the concepts. Concepts are pretty simple. We want to open all dimensions of the velopharynx and oropharyngeal airway. We want to open the superior inferior dimension, the lateral dimension, and the anterior posterior dimension. and we want to address the anatomic variations that exist there. So if this is a normal exam where there's a fairly open oropharyngeal inlet here, sure, there's tonsils, but they're not terribly obstructing. You can appreciate a shadow here. There's a little space between the palate and the back wall, and the vertical dimension and lateral dimensions are both pretty good. So this is a reasonably normal exam. Actually, quite normal exam, a lot more normal than what I see in my clinic. There's a whole host of ways to address abnormalities that I'm going to show you with variations and variants of UPPP. The old way of just cutting off palate is something that I haven't done for over 10 years, and that's the way I was trained to do all UPPs. So the point of this is to show there's a lot of variation even within this one operation. Here are 6 variations of Uvulopalatal Pharyngoplasty. This is not an exhaustive list, but this is a list of things that I do commonly, so I thought I would highlight these. So for the elongated soft palate, where when you look in the mouth, and even with a tongue depressor pushing down on the tongue, all you see is palate. You can't even see the posterior pharyngeal wall. So it's elongated. In this case, if you pull the uvula out, you can see a little bit of space back there. So this is an issue of a small superior inferior dimension. In this case, I prefer the Uvulopalatal Flap, which is described here with Nelson Powell and the group there. And it's different from resecting the palate in that it's folding up the palate. And a key feature of that is it preserves the musculature of the palate. That has some potential advantages, one of which is less morbidity, swallowing morbidity with the procedure. So removal of tonsils, demucosalization of the palate, and then just rotate up a little flap of uvula and soft palate. So most of my patients don't have just isolated length issues. A lot of them have issues that go down the side walls. And so a variation of this has been described called the extended Uvulopalatal Flap. This is described by Xiuyu Li, who's from Taiwan. And it's the same thing with the rotating the flap up, but then working it down the sides. And even more than is described in this paper, I'll go all the way down to the vallecula with the lateral pharyngoplasty part of that. So here's an example of a patient who has a small superior inferior dimension as well as a narrow lateral dimension. And here's after he's healed up from uvulopalatal flap and an extended uvulopalatal flap. So here's the uvula and palate part folded up, and then you can kind of appreciate the sidewall here has been folded over. And if we were to look all the way down, you can see retraction laterally all the way down to the vallecula. Incidentally, the back side of the palate is more injected than the front side. It's not infected. It's not inflamed or erythematous. It's just the color, which is kind of nice because then you can see your, take a picture of it later and it's visible. Another key feature of this version is the scar is all on the anterior face of the palate. It's not along the edge. So one of the morbidities with the traditional UPPP was the scar band along the edge. Probably created some of the swallowing morbidity. So why the uvulopalatal flap? Suture line interior, tissue preservation. You also get a bit of an anterior vector of pull when you put that flap up, so you can open up the AP dimension just a little bit. And in theory, less velopharyngeal incompetence, and it's theoretically reversible. How about thick lateral musculature? So this setting where here's the anterior pillar, but the posterior pillar just has a thick palatopharyngeus muscle. The height is fine. It's just the lateral dimension's thickened. Or when you're looking with a flex scope exam into the nasopharynx and you see thick torus tubarius, and then on a Mueller maneuver, that's what collapses. Not the front to back, but the side to side. In that setting, I prefer to use this technique, expansion sphincter pharyngoplasty, described by Kenny Peng and Tucker Woodson. The idea here was kind of trying to do the opposite of a cleft palate procedure where you take the palatopharyngeus and you rotate it up behind the cleft so that you can actually constrict the velopharynx. Here, you cut the palatopharyngeus muscle, free it up, and then reflect it laterally so you get a dilating effect. Not sure if you actually truly get a dilating effect with the muscle, but you certainly get a tension laterally, and it pulls the tissues laterally. Now, you might think that's going to radically affect swallowing. It doesn't. Patients recover of swallowing just fine without their palatopharyngeus intact like that. I do a modified version of this where I also suture up the lower limb laterally, and it allows me to stabilize the lateral collapse that may be occurring a little further down. Here's an example where I applied it where there was lateral narrowing, not due to a thick palatal pharyngeus, but due to scarring. So this is a patient that had layup procedure and had repeated layups to try to address abnormal scarring, and it resulted in this stenosis of the oropharyngeal inlet. So here's the patient 4 months after expansion sphincter pharyngoplasty, where I basically just cut the lateral scar band and whatever muscle was in there and retracted it up laterally. This is still not normal. This is still very abnormal, but it's a lot better than it was. These oropharyngeal or nasopharyngeal stenoses are notoriously hard to address. And so this technique, I think, allows one to address at least the lateral dimension if that's where it's constricted in a relatively simple way that tends to recover well. So why the expansion sphincter pharyngoplasty? Lateralizes and tightens the lateral oropharyngeal musculature. It can be combined with the Uvulopalatal Flap if there's too much length. That's easily combined, and it's fairly simple. So this is a very different operation from the Uvulopalatal Flap. They're both UPPP, but they're actually on different structures within the oropharynx, and they achieve different objectives. One, shorten, one, widen the airway. This expansion sphincter pharyngoplasty was based in part on a fairly radical version of uvulopalatal pharyngoplasty called lateral pharyngoplasty, described by Michel Kahali in Brazil. In that technique, in addition to removing, after removing the tonsils, he would actually divide the superior constrictor muscle. He would suture the palatal pharyngeus and part of the superior constrictor muscle deeper into the parapharyngeal space, and then close it back over with overlapping anterior pillar. He'd also dissect up laterally here up toward the hamulus and suture that up. It's this part that we try to recreate with this expansor sphincter pharyngoplasty. And one of the keys to this, and I don't know if Michelle realized this or happened upon this, is across the top of the soft palate, you have the tensor veli palatini aponeurosis. It's really robust tissue. So you can really anchor something with tension up there and it holds, and that's key. So you can pull things open or laterally with a good anchor point. The rest of this is all pretty flimsy, and you tend to get dehiscence if you rely on suturing to these other soft tissue structures nearby. Michel no longer does this operation because he was getting too many major complications dissecting into the parapharyngeal space. So he, when I most recently talked to him, he's working on a modified version. He doesn't really do this, but this was a key development because it's allowed us to develop some of these other variations that are not as aggressive but take advantage of some of the benefits. He demonstrated with this radical UPPP major improvements in the sleep apnea relative to standard UPPP. So this is actually a randomized trial comparing a standard UPPP with a lateral pharyngoplasty technique. And just looking at the AHI, he got a 62% improvement in the AHI with his technique compared to 14% with the other. And most of the parameters were dramatically improved in his technique over the other. The problem was the complications. All right, how about the anterior posterior dimension? There, we're paying attention to the space behind the palate, the velopharyngeal port. So, if it's normal in this configuration, there's some patients for whom it just sits back too far, either because the hard palate is too long, and so the soft palate just follows, even though it's vertically oriented, it's just too far back, or for some, the soft palate is just oriented in such a way it's oblique and it reaches the back wall too easily and can occlude that part of the airway. So here's a view of a normal velopharyngeal port from above. Nice big space, anterior posterior space here. You can see the larynx pretty easily. This is a sleep apnea patient, and this part of his airway is a bit compromised because the epiglottis is retroflex, big tongue, but the velopharynx is pretty good. Very good, actually. Here's a patient picture that's pretty common, though, that we see with sleep apnea, especially severe sleep apnea, where the space between the anterior and posterior part of the velopharynx is very narrow. In fact, in this case, it's touching, and there's only this lateral port here. This is with the patient sitting upright and awake. You can imagine if they're asleep and lying supine, it would be even further compromised. So in this situation, if it's a soft tissue draping back, I do a variation of UPPP called Lateral Palatopex. This is not written anywhere, so you're not going to find it in the literature. It's just a variation that just sort of tweaking with sutures and so forth I've stumbled upon and find to be helpful. It takes advantage, like I said before, of the tendon of the tensor veli palatini being right here, very robust, and the aponeurosis across here. What involves is, that's the hard palate. What involves is passing a suture right into and through and around the musculature where the levator muscle attaches to the palatopharyngeus and palatal glossus muscles. And when you do that and you get a good robust bite, you can actually pull the palate up off the back wall readily. You could, in fact, almost pull their head off the table. Then you pass the suture submucosally up to this aponeurosis and loop it around. That's also very robust. Put it back down through the same hole so it buries itself and come out through the fossa. Now, if you've removed the tonsils, there's a raw area here. If the tonsils had previously been removed, then I'll demucosalize this just so the suture will all bury. And when you do this and you snug down the suture, and if you do it well, you'll watch the palate just come up off the back wall. And it really opens up the AP dimension nicely if it's a soft tissue positioning problem there. Here's an example of one. This is a patient pre-op, somewhat narrowed velopharyngeal AP dimension, and here's this patient post-op. I usually place them laterally, and occasionally I'll place them medially as well. So why this technique improves the anterior vector of pull, can be combined with Uvulopalatal Flap. It's easy and it's fast. Patients do not get velopharyngeal incompetence with this. If you do this in isolation, I've never seen VPI, and even when combined with Uvulopalatal Flap, don't. And I think the key there is that you're preserving the musculature. And the musculature can adapt to still close off. It's just its relaxed position is no longer sitting backwards. It's sitting more forward. If the bone is too long, so the soft palate is just draping straight down, but it's draping straight down right next to the back wall of the pharyngeal wall, then you need to do a bony procedure. Now, if you do a bimaxillary advancement or even a maxillary advancement, you'll get the advancement of the palate. But it's rare that you have the setting of severe class 3 malocclusion due to midface hypoplasia that you're going to do just a maxillary advancement. And doing a bimaxillary advancement is a big operation. A lot of patients aren't interested in going that far. Tucker Woodson developed a technique that's kind of, he coins it a poor man's maxillary advancement. And that is, rather than advancing the whole maxilla, you actually just take out a segment of bone. And it turns out that's a pretty simple operation to do. So the approach here is from within the mouth. You expose the hard palate. This is described as a Gothic arch with a little limb. Now, most of us just do a propeller incision. Expose the hard palate, remove an interval of bone in there, leave a little bit of bone on the posterior part, attach that aponeurosis and the rest of the soft palate, drill a couple holes in there, put a suture in there, and pull this forward. You're just pulling the whole soft palate forward. And then close it up. It turns out this is much better tolerated than regular UPPP because the area of dissection is a lot less sensitive. It can be combined with other UPP variations like Uvulopalatal Flap, lateral Pharyngoplasty, or others. I usually use this in the setting of a salvage, so I've done a UPPP and it failed, or when I'm really convinced that the hard palate is just too long. Here's some data from Tucker's description of this, and the Palatal Advancement Pharyngoplasty was matched with standard UPP patients. This is a cohort study, a matched cohort study, so they had the same baseline severity of sleep apnea, and the Palatal Advancement reduced their apnea-hypopnea index down to 20, whereas the standard UP was down to 31. So it was a bigger change relative to UPPP. It was in selected patients, of course, where they did the Palatal Advancement Pharyngoplasty. So I don't have any good slides to demonstrate measurement of that velopharyngeal space, so I thought this is a pretty good way to measure the velopharyngeal space. Did I show this video last time? Okay, maybe not. So if the patient can do this, you know the velopharynx is open. They can put their tongue behind it, and then when you look with a scope in the velopharynx, they can kind of like wipe off the back part of their soft palate, then you know you have a good open velopharynx. Okay. Why palatal advancement? Anterior reposition can be combined with other variations of UPPP. It can be used to salvage prior UPPPs, and it's well tolerated. Certainly less invasive than maxillary advancement. It's actually better tolerated than a standard UPPP or a soft tissue UPPP. So to summarize about UPPP techniques, try to open all the dimensions. We try to address the anatomy where the anatomy is abnormal, and there are multiple variants available to apply. So I think that is a microcosm of sleep surgery as a whole. Sleep surgery as a whole is not bimaxillary advancement. That's one piece. It's not UPP alone. It's where's the anatomy abnormal, where's the physiology abnormal, where's the function abnormal, and let's try to address those things. So it's very targeted, and even within a given procedure, it's targeted. So now I'm going to move on to talking about UPPP outcomes. So here are some key questions regarding UPPP and outcomes. This is a question I get a lot. Doc, does it work? It usually starts with, Doc, I heard it doesn't work. Does it work? And then I have to ask them back, well, it depends on what you mean by it, and it depends on what you mean by work. And then there's a long conversation that follows. So I'm going to talk to you about whether or not it works. Second question, is it safe? So it might be great outcome for the sleep apnea, but if it's not safe, it's not a good option. And that's exactly what happened with Michel Kahali's version. He had really dramatic improvements in the sleep apnea, but he quit doing it because he had some profound bleeds. And so it wasn't safe enough. How does it compare? How does it compare to other surgical treatments? How does it compare to non-surgical treatments? And then maybe in today's world, most importantly, is it cost effective? Because that's what's going to drive whether or not we do a lot of the treatments that we're doing now. Important caveats about UPPP. First of all, surgical treatment for sleep apnea, in my mind, in adults, is largely second-line treatment. The UPP specifically is a second-line treatment when there's velo or oropharyngeal obstruction. If the patient has a big tongue, don't expect this to solve their problem. This might be necessary to also address the upper pharynx, but it's not going to solve the problem by itself. So this is an isolated procedure I'm talking about that's rarely applied in isolation. It's often combined with other surgeries, and UPPP is not equal to sleep surgery. It's a subset of sleep surgery. Okay, how about the context in which to answer these questions? There's research-based context. So we're all familiar with the terms evidence-based medicine. The concept of evidence-based medicine relies on current best evidence, and that's what I'm going to try to talk to you about. There's other important elements, patient preference and clinical judgment, that are equally important that I'm not going to talk about. I'm going to focus on the evidence here, but I always like to point out the context in which we're looking at the evidence. A second comment about evidence-based medicine it's based on randomized, double-blinded, placebo-controlled trials. It's based on best available evidence. Now, how do we define best available evidence? There's actually categories on evidence quality or strength of evidence. And this is a paradigm that's commonly used, described by David Sackett, kind of a father of evidence-based medicine as it's currently described. The highest level of evidence is a randomized trial. Then non-randomized trials or cohort studies, then case control studies, then case series, and opinion. And the order there comes from the strength of the internal validity of data that comes out of these study designs. It turns out that it's inverse to generalizability, and that's a problem. Now, you can do a randomized trial and have a really robust answer about the patients who are eligible for that trial, but usually it's a very small subset of people who are eligible for the trial, and it may not apply to your real-world practice. That's one of the inherent challenges of using only highest level evidence. If it doesn't apply to your patients, it's not useful. I want to describe UP outcomes in context of evidence-based medicine. In fact, I want to describe an example of a study in each of these categories that we've done, where we're trying to address various issues that require different methodologies. There are other study types. There's evidence reviews and grading. There's meta-analyses. There's cost-effectiveness analyses. There's descriptive studies that sometimes can be critically important in moving the field forward. And then there's subgroup analyses, which right now is gaining a lot of attention with the whole PCORI thing, Patient-Centered Outcomes Research Institute push, where you want to really personalize the therapy to an individual's given situation. There's different data sources and data types, primary data versus secondary data, clinical data versus administrative data. Administrative data is sometimes very useful to answer questions that can't be answered with clinical data for practical reasons. There's individual data from individual studies, and there's metadata from combining studies. There's empirical data and there's model data, meaning data you collect on measuring patients versus model data where you create a statistical model of what you predict to happen, like in a cost-effectiveness analysis. Prospective and retrospective each have their strengths and weaknesses. And I would even argue where the data is collected. You know, data collected in an academic setting may be very different than data collected in a community setting and how it's applied and how applicable it is. If most of our data is collected in academic settings and it doesn't apply well in community settings, the vast majority of treatment's actually occurring in the community and it's not potentially relevant. We want to try to incorporate both. So I'm going to work my way up from the bottom and give examples of each of these. So level 5 is opinion. Typically, that means consensus opinion. It's not just one person's opinion, but consensus opinion. The advantages of level 5, first of all, that's evidence. You don't have to have a randomized double-blinded placebo-controlled trial to have evidence. All these are levels of evidence, including opinion. The reason opinion is evidence is because it's a synthesis of information. The pros are it allows you to fill those gaps in knowledge because you can't do a trial for every single clinical decision you make. In fact, there's a trial on almost none of the clinical decisions you make. And it's relatively simple. You just got to get people together and come to a consensus. The con is it's highly prone to bias. And that's the reason why it's the lowest level. There are approaches or solutions to try to minimize that bias. There are rigorous methodologies to come to consensus. So one of them is a Delphi Method. That was what was applied in the example I'm going to give. And then once you come up with opinions, you should try to test those opinions with data gathering and modify the opinions if the data contradicts the opinions that were established. So here's an example of level 5 evidence. This is a clinical guideline for the evaluation, management, and long-term care of obstructive sleep apnea in adults. So I was on this task force by the American Academy of Sleep Medicine to put together this guideline. The purpose of this guideline was to fill in the major gaps in what we should be doing clinically for patients, the major gaps in evidence, major gaps in data. So it's a long paper, talks about CPAP, oral appliances, outcome measurements, diagnostics, and so forth. Here's the flow chart for surgical treatment. And the gaps are wide in what we should do when, and that's filled in with opinion based on consensus using this Delphi method. The Delphi method is where you identify the gaps in knowledge in need of consensus, you draft consensus statements and variations of consensus statements, then you do a secret ballot to vote on them, and it has the advantage of each participant has equal input, because sometimes what happens on these task forces is you get a vocal person who dominates it and you really get an opinion of one person rather than a group consensus. All are required to vote. You can't abstain. So it's an attempt to be a little more rigorous to try to minimize the bias of a single person. The main consensus points for this consensus statement regarding surgery were a number of issues here outlined here. I'm not going to go through each of these. We developed statements for each of these and then voted on them, and that's summarized in that guideline. So that's an example of level 5 evidence, opinion, and that's actually cited for a policy on what should be done in the treatment of sleep apnea, where other evidence is lacking. Okay, level 4 evidence is case series. This is the classic before-after study, where you have an exposure in epidemiologic terms or a treatment in outcomes terms, and then you look at the outcome later on. No control group. This is where most of the sleep surgery literature exists. We did this operation, here was their apnea-hypopnea index before, here's what it is after, and it helped. The pros of this type of study is that it's pretty easy to do, and it's intuitive, because we do this every day in our clinical practice. When you treat a patient and you see them in follow-up, what do? You ask them, hey, are you feeling better? Are you doing better? You don't have a control patient that you did a sham procedure on at the same time to measure how much better your actual patient got. You do a case series every day in the clinic. It's clinically intuitive. The con is with no control is you don't know what would have happened without your treatment. Now, sometimes it's obvious. So a classic example is if someone comes up with a cure for rabies, you don't need a control, because rabies is incurable right now. And so that's an example where you can be convinced that the therapy is working if the patient lives with rabies that was not addressed with the shots and stuff ahead of time. Ways to minimize the bias that is inherent with no control group is, first of all, try to use validated measures. The other is, if you see big effects, it's likely there's a real treatment effect. If you see small effects, that's when I think you got to be really suspicious that if you had a control group, there might not have been anything there. So you don't want to overinterpret the results, but if you see large consistent effects, then that's favorable. Here's an example of a case series. This is the sleep study. This was sponsored by the American Academy of Otolaryngology. with the best ENT group, so the nationwide community and academic-based network. So strengths of this study, despite its level 4 study design, are, number one, there were 44 sites that patients were enrolled from. More than half of them were community-based. So it's generalizable. That's really important. Number two, we used robust measures of sleep apnea, subjective outcomes, symptoms, and quality of life. That was another strength. A third strength is the degree of the results. So here's looking at quality of life outcome with UPP. These are isolated UPP patients. They did not receive any other surgical treatment. It's a subset of a larger cohort that received multi-level surgery. So this is looking at the subset that got just UPPP. Looking at the functional outcomes of sleep questionnaire, which is a highly validated, extensively used sleep-specific instrument that scores from 5 to 20, where higher is better. Anything above 17.9 or above is considered normal sleep-related quality of life. These patients at baseline had a pretty significant deficit down to 14.3. A 1-point change is considered a clinically important effect. 3.5-point deficit is a large deficit on this instrument. So this was where the UPPP patients were before they received treatment. 3 months after treatment and stable, again measured at 6 months after treatment, their quality of life was almost normalized. We didn't measure sleep study outcomes in this study because it was 44 different sites. They all had different ways of measuring that. We didn't even bother to measure it. Plus, we were on a shoestring budget. It was funded by the Academy, so we were just looking at subjective measures. So here's quantitatively that result I just described. Looking at symptoms, they were all statistically improved. In fact, they were dramatically statistically improved. So for example, the Epworth Sleepiness Scale went from almost 13, abnormal is 11 or above, down to 7, which is square in the middle of the normal range. Sleep apnea symptoms, awakening with headache, sleep apnea, how much of a problem sleep apnea is on a visual analog scale, snoring on a visual analog scale, and global sleep apnea quality of life change were all dramatically improved. Now, if we had sleep study results on these, I can guarantee you that very few of the patients would have been cured of their sleep apnea with an apnea-hypopnea less than 5. But interestingly, their symptoms are almost normalized and their quality of life is almost normalized. The clinical effect is bigger than the sleep study effect has been shown in other studies. So highlights here, big one is it's generalizable. It's community and academic based, geographically diverse, 17 different practices. Sorry, the 44 was for all the combined ones. 17 had isolated UPP data. And we had a flexible definition of UPP. We had this very general working definition. So the UPP was done in at least 17 different ways, and some of the practices had more than one surgeon, so it was probably done in more than 17 different ways, and you still get this result. That's a lot more generalizable than if we had a specific trial where everyone did it exactly the same way, and that's not the way you do it. Then you don't know if the way you do it would get the same result. It was prospective, validated outcome measures were used, and there's big effects. So I think this is an important contribution to the literature, even though it's a level 4 study. Okay, how about level 3 studies? That's the case control study. The design of a case control study is one where you find the patients by finding the ones who had the outcome you're looking for and ones who didn't have the outcome. Then you go back into their records and look to see whether they had an exposure. That's not a natural way to think about this. Usually you think, well, let me have a cohort of patients with an exposure and the ones who didn't have the exposure, or a treatment and didn't have the treatment, and let's see how the outcome is. There's a reason for this case control study to be backwards, which I'm going to touch on in a second. First, the pros of this, it has a control group. So that makes it a level above the case series, which has no control group. It's particularly good for rare outcomes. The cons are it is retrospective. It's inherently retrospective. Every case control study by definition is retrospective, and that introduces recall bias. There's also potential confounding where a third variable might affect the association between the exposure and the outcome. That's true of any observational study. This falls into the category of observational studies and one that you need to try to address when you're doing it. The way you address confounding, in the case control studies, you try to match the controls to the cases, and then you adjust for other potential confounding variables in the statistical analysis. A second way to try to mitigate the bias of it being retrospective is that you select clear predictors. So one of the problems with a retrospective study design is you're measuring the predictor after the outcome already occurred. Can you be guaranteed that the predictor was there before the outcome occurred? Well, in some cases, it's obvious. In those cases, you're going to have a stronger version of a case control study. In some cases, it's not obvious, and it'll be weaker. So here's an example of a case control study looking at risk factors for serious complication after uvulopalatal Pharyngoplasty. This was a nested case control study embedded in a larger cohort study. The larger cohort had over 3,000 UPP patients. However, we wanted to look at risk factors that were not available in the cohort database. So we had to go to the charts. And we have a rare outcome. Complication is rare. So rather than look at 1,000 charts to find a few cases, we looked in the cohorts database and found cases of patients who had had a serious complication and then went back to their charts to look at these risk factors. We also drew from the cohort database a sample of patients who didn't have the complication but were matched on age, sex, and year, and then looked back to see if they had the risk factors. We had 43 cases, so out of 3,000 UPP patients, there were 43 cases of serious complication. And then we took 4 times as many controls to add to statistical power that was still within an acceptable burden of chart review. The data were administrative data, meaning based on ICD-9 codes. And we did this because there were some risk factors that were not available in the cohort data set. It's a rare outcome, so that's why we use a case control study rather than just sampling a bunch of charts for exposures and then looking at outcome. So here's the sample. Here are the case patients. Here are the matched control patients. The ages are the same because we matched on age. The percent of males was the same because we matched on sex. The BMIs, the BMI, the AHI, the lowest saturation, and the Charlson Comorbidity Index were the risk factors that we're looking to see if they were different between the two. And it turns out BMI, AHI, and the Comorbidity Index were different between the two, but the saturation wasn't statistically different. So the case patients, the patient who had serious complication had worse sleep apnea measured by AHI. They were more obese, measured on body mass index, and they had more comorbidity. None of these is a shocker, but nobody had tested this before. Now, this isn't the definitive analysis because this is just comparing straight up the two. It's not adjusting for potential other confounding variables. So when we adjust for other potential confounding variables, things like smoking, race, other demographics, other health states, it turned out that when we adjust for some of them, AHI was still was a trend toward being a significant predictor of serious complication. They all had point estimates that suggested they were predictors for serious complications. However, when we adjusted for the full adjusted analysis for all the variables we thought were potential confounders, none of them were statistically significant. Now, the conclusion there is that there's multiple risk factors, but they weren't statistically independent. In other words, body mass index may be a risk factor partly because you're more likely to be a sick person and have a worse comorbidity index if you have a high body mass index. So teasing those apart would require even a bigger sample. It was retrospective, but risk factors preceded the outcome, so that's important for trying to establish cause and effect between the risk factors and the outcome. And this allowed us to look at the chart data rather than just administrative data, so it was, in fact, clinical data, which strengthens the results. All right, how about a level 2 study? This is a cohort study. This is a classic study where you have a cohort of patients, you look to see if they have an exposure or received, in the case of an outcome study, received a treatment or not, and see if they have the bad outcome or the good outcome or not. So this is a classic epidemiologic cohort study where it's exposure versus outcome. Non-randomized trial, or some people will call this an outcomes study, is one definition of outcome study, is a cohort study where the exposure is a treatment. Treatment A versus treatment B, or treatment A versus no treatment, and looking at outcome. The pros of a cohort study: you have a control group, so that's better than a case series. It's practical. It's relatively easy to get large samples when you're doing an observational study, just looking, identifying patients who got a treatment or didn't, and just following them over time. It is easier to have generalizable results in that case, again, because it's observational. The cons are, like with the case control, is confounding. There may be other variables that explain why the patient got better or didn't get better besides the treatment. And selection bias. How did you decide who got the treatment and who didn't get the treatment? Who got treatment A versus treatment B? And that's a key limitation of this type of study design. So for example, let's say you're comparing CPAP to surgery. Well, if we pick all the patients who are relatively healthy and are very compliant and give them surgery, and we pick all the patients who are otherwise unhealthy and non-compliant and give them CPAP, the surgery patients might look like they did better just because we selected for patients who are more likely to get better. Solutions to this are, number one, try to have broad inclusion criteria so that you don't have pre-selected bias going in, and adjust for confounding variables in the statistical analysis. So here's a couple examples of cohort studies. This is an epidemiologic cohort study looking at incidence of serious complications after uvulopalatal Pharyngoplasty. So this is the cohort study upon which the case control study was nested in. 3,000 patients, 123 VA medical centers. It's all inpatient UPPs done in these VA medical centers over several years' time. Very generalizable, at least within the VA, because every single UPP that was done contributed to the data. It was administrative data, relied on ICD-9 codes. There were rare outcomes, so you might think we should have done just a case control study. However, it was easy to get all the data because it's already in existing databases, so it's not screening a bunch of charts. We just download the database, and that's why we use a cohort study design with this, even in the setting of a rare outcome. The reason we did the case control study before was for data that weren't available in the database, where we did have to go to the chart and wouldn't have been feasible to screen 3,000 charts. Here's quantitatively the rates of serious complication with pretty tight 95% confidence intervals because we had a big sample. I can go through the details of the results other than to say that serious complications are rare. That was a significant contribution to the literature because all previous studies had been small studies, a cohort of 100 patients or so. Mostly in centers, including the University of Washington, which was one of the first ones, where there had been a death that motivated someone to study this. So you have the one death that motivates you to study it, you have 100 other patients, it looks like the death rate is about 1%. The problem is the 95% confidence interval is like minus 10% to plus 20%. It's a huge interval. You can't tell really with any precision what the true rate is. And there's a publication bias because if you just took 100 patients and you had no deaths, you're not going to get that published because they say you had too small of a sample. But if you have a death, they think it's a legitimate sample because you had an event. So you're selecting for the samples that had events. There was about 5 or 6 of these, and they varied widely in the rates of complication, but they all had wide confidence intervals. So this added value in that it was large and allowed us to get some precision around that estimate. All right, here's the second cohort study, and this is more of an outcomes type cohort study or non-randomized trial. The research question was, how does long-term survival compare between UPPP, CPAP, and no treatment? So there's actually 3 risk categories or treatment categories. Again, large sample using nationwide VA data. The population is veterans with sleep apnea. The exposure is treatment, whether it's no treatment, treatment A being UPP, or treatment B being CPAP. The outcome is death. Multiple covariates were adjusted, potential confounders. Critical among them is comorbidity. For a survival analysis, the biggest confounder by far is comorbidity. And adjusting for a robust measure of comorbidity is really key in any survival study. That was actually unique to this study. The previous comorbidity adjustments in the previous studies that had been done were usually selected 2 or 3 comorbid conditions rather than an index of multiple conditions. The Charleston Comorbidity Index that we used has 19 conditions. By far and away the most widely used comorbidity index. Here's a look at the cohort in terms of those who are untreated versus those who are treated with either CPAP or UPPP. Big sample. Statistically different in all these categories because we had such a big sample. Age was slightly younger in the treated group. So you might argue if the treated group did better than the untreated group, it might just be because they were younger and healthier. But if you adjust for that, you can draw a conclusion regardless of the fact that they're different at baseline. Likewise, sex difference, race difference existed. The treated patients were slightly less sick than the untreated patients. Higher score in the comorbidity index is worse comorbidity. Here's the crude outcomes, but it's better depicted on the graph. This is a survival curve, Kaplan-Meier survival curve, going out 13 plus years. At the time of sleep apnea diagnosis, every patient was alive. That's good. If you're dead, your apnea, you only have one apnea. It lasts a really long time. Here's the course over time. If you had sleep apnea and didn't get treatment, at about 13 years, about 60% were still alive. If you received a CPAP device, about 70% were still alive. If you had a UPPP, about 80% were still alive. Now, I got to point out, the CPAP patients weren't patients necessarily using CPAP. They received a CPAP. The VA is really good about tracking about who got surgery, who got a CPAP. They're not necessarily consistent, very good about tracking who used their CPAP. So I'm not saying that surgery is better than CPAP. I'm saying surgery is better than just receiving a CPAP. If you use your CPAP, it's probably better. We were not able to look at that question specifically. Adjusting for a host of potential confounding variables, there's a highly statistically significant benefit of getting treated versus not getting treated for your sleep apnea. Your hazard of dying at any moment in time if you were treated was 0.53, that as if you were untreated, this being the reference. We didn't have those data in this data set, but yeah, that's a potential confounder. We did have race, which is somewhat a proxy of that, but we didn't have a specific socioeconomic variable. The most important one thing is comorbidity. I'll highlight here, we did not have sleep apnea severity, and that's a major criticism of these data. I don't think that's a critical flaw, and here's why. Sleep apnea doesn't kill you. What kills you is the morbidity that sleep apnea causes. So nobody's death certificate says they died from sleep apnea. It says they died from an arrhythmia that killed them that may have been induced by the sleep apnea or died from their myocardial infarction. So sleep apnea is one step in a pathway to death, but it's not the terminal event. The terminal event is other comorbidity, and we adjusted very robustly for the other comorbidities like cardiovascular disease, cerebral vascular disease, endocrine disease, and so forth. So the fact that we had a robust comorbidity index, I think the lack of adjusting for sleep apnea severity makes that not a critical flaw. Now, critics will say, yeah, your treated patients had less severe sleep apnea, and that's why they got better. And I would argue that's probably not true. And it turns out in other studies that are smaller that do adjust for sleep apnea severity because they have those data available, show the exact same results. Now comparing among the treated patients, comparing UPP versus CPAP, UPP actually had a reduced hazard of dying at any moment in time relative to receiving a CPAP device. This is the same data, just looking at those two subsets. Now, I'll hasten to point out again, CPAP is defined as receiving a CPAP, not necessarily using it. So the criticism about severity of sleep apnea more came in comparison of UPP to CPAP. People were criticizing that the UPP patients probably had less severe sleep apnea. It turns out in that nested case control study, which is the same cohort of UPP patients that we looked at here, the surgery patients had severe sleep apnea. Desaturations to 70%, AHIs of 54. So I don't think the UPP patients were mild sleep apnea patients. They're actually severe sleep apnea patients on average. We happen to know. That was not in this paper. That was subsequently determined in our chart review for that other study. How can it be that the polysomnography outcomes are modest with UPPP, and we know they are. I haven't presented data on that yet, but we know that they are from studies that are out there. How can PSG outcomes be modest, yet clinical outcomes be so good? And there's a variety of reasons, plausible explanations why that could be. At first blush, most people reject these data as impossible. But if you think about it, it is impossible. For starters, we're measuring on polysomnography typically the apnea-hypopnea index, and the apnea-hypopnea index misses important treatment effects. So, for example, if your hypopnea definition does not include a 4% desaturation, there's data to suggest it has no correlation or no significant predictive ability of cardiovascular morbidity. If it does have a 4% desaturation, it does predict cardiovascular morbidity. What happens if we turn these apneas that predict cardiovascular morbidity into hypopneas that don't have desaturations with them? Your apnea-hypopnea index hasn't changed, but your physiology's changed a lot. Sleep apnea progression is slowed even if it's not halted. When you look at this curve, these patients do die over time. They just die at a slower rate. So if you measure a sleep test here, there's probably worse sleep apnea than if you measure a sleep test here. Some would argue to say the UP didn't do anything. Their sleep apnea is getting worse. I would argue, if you compare it to a control patient measuring their sleep apnea here versus here, they got worse slower. That's an explanation of how their mortality rate is reduced, their survival is improved, yet their sleep apnea is not cured. You change the progression of the disease. It is a progressive disease, and you change that. You shift the curve. The effect occurs 100% of the time. So the CPAP patients receive the CPAP, some of them are wearing it 0% of the time. And that's probably why their curve is not as good as the UPP curve. You get a partial effect, but you get it all the time. So a big question in our field is a partial effect all the time as good as, better than, or worse than a complete effect part of the time? You can't answer that question until you know how much of an effect in the CPAP and how much of the time. That's a question that needs to be answered, is how much CPAP is necessary or how little CPAP is necessary before we should be considering surgery. Another interesting plausible explanation for why survival might be improved with UPPP when it doesn't cure the sleep apnea is there's data now emerging that suggests that snoring itself might be an independent risk factor for stroke, independent of sleep apnea. And the concept here is vibratory trauma localized to the carotid arteries. There's data to suggest that snorers get atherosclerotic plaques in the carotid arteries when they don't in their other arteries, independent of the degree of sleep apnea. There's a robust literature on vibratory trauma causing neuro and vascular damage. So maybe UPP is improving people's survival by just reducing their snoring. So surgery, the conclusions I draw from these data is that surgery is better than partial CPAP use. Problem is we don't know the threshold of CPAP use where surgery is better. That's still unknown. The question we need to answer. If I had to guess, well, it depends on the outcome. There's enough data to say that it probably depends on the outcome. The current standard of 4 hours a night, 5 nights a week for CPAP is arbitrary for starters. It's developed by Terry Weaver, and she will readily admit that that was an arbitrary cutoff. And that's probably not sufficient for most outcomes. It might be for some, though. This was based on administrative data. It did include all VA medical centers. Every UPPP done in this time interval is highly generalizable. No matter how the people did UPP, it was included. It is a secondary data analysis. These data were not collected for studying survival. These data were collected by the VA for administrative purposes. However, we're able to use it to get answers about survival. We use survival analysis, which is a robust, adjusted analysis. All right, level 1 study, randomized trial. This is the highest level evidence. The design here is the same as a cohort study, outcome study, with the key difference that you don't just assign the treatment by any arbitrary way or by patient choice or by surgeon choice or by physician choice. It's by random selection. And it has to be very deliberate random choice. And that removes the selection bias between treatments. And because of that, that's the highest level of evidence, has the best internal validity. Pros, it's a control group. The lack of selection, but no treatment, selection bias is key. And then the other thing I must mention is when you randomize between two groups, there's a key effect of randomizing. And that is the two groups will be balanced. Why is that important? The problem with confounding, where there's a third variable that comes into play, is when it distorts the relationship between the treatment and the outcome. And if it's different between the two groups, that's when you have a problem. And with randomization, you balance the confounders also. And not only do you balance the known confounders that you could have addressed statistically, you balance the unknown confounders that you're not even aware of. And that's a critical advantage of randomized trials. The con is they're impractical, they're costly, and a lot of times they don't generalize to our everyday practice. The best approach to randomized trials, in my opinion, is to try to replicate real-life conditions so they're as generalizable as possible, but sometimes that's impossible to replicate real-life conditions. So here's an example of a UPP randomized trial. These are data. I'm not going to present the data because they haven't been presented before. This is a preliminary subset of the data that's going to be presented at the World Congress of Sleep Apnea in Rome in August. But I'm going to present to you the study design here. So these are patients who met certain criteria for UPPP, and they were randomized to either receive a UPPP or to not receive a UPPP, but they're guaranteed they could get their UPPP later, 6 months later. And then at 6 months, they were assessed for outcomes as the randomized comparison. The patients who were delayed then could get their UPPP, and now they're no longer in a separate randomized group, and they're followed, both groups are followed longer term to see if the results are stable. So this is being done in Reykjavik. So I was in Reykjavik in 2005 when we were designing this. The reason they're doing this is that they're doing this other major study with genetics, robust phenotyping of the patients, and they thought this is a good opportunity to tack on a surgical intervention. They're also doing MRIs, surgical intervention within the cohort. There's a parallel study going on in Stockholm that's also going to be presented at the World Congress of Sleep Apnea that actually had much faster enrollment, and so I think they're presenting their final results. The inclusion criteria, they had to have sleep apnea. In fact, they had to have moderate or severe sleep apnea. The cutoff was 15. They had to not be abnormally low Epworth Sleepiness Scale, but 7 still within normal. They couldn't be morbidly obese. They had to have tried and failed CPAP, and they have to have anatomy that's conducive, at least in part, to UPPP, Friedman 1 or 2 staging, for those familiar with that. The treatment groups were UPP or delay. The target sample size is 64. So far, there's only 7 in the UPP group and 8 in the delay. They started enrollment about 2 years ago. There was more than 15 UPP patients done in 2 years. And this is what gets at the generalizability. How many patients are willing to let the delay of their surgery be determined by a flip of a coin? Not very many. Outcome variables, among them, these were the primary ones: apnea, hypopnea index, and Epworth Sleepiness Scale, and then a variety of others at 6 months. So, notes, slow enrollment. And that is a testament to the reason why we don't just randomize patients. I mean, I get that comment a lot from people who are critical of our literature. Why don't you just randomize? On paper, that's easy to do. In practice, it's not necessarily easy to do. This study is in a single center by a single provider with a single type of UPPP. So if the results are favorable, it's only speaking to one very specific type of procedure. We also are evaluating predictors, which we think will be a really interesting part of this. Important to note is this is a randomized trial, but it's not placebo-controlled and it's not double-blinded. So it has good internal validity in terms of confounding, control, and that stuff, but there's still room for biases. In fact, there's room for really important biases, like placebo effect or unblinded outcomes assessor. We haven't figured out how to do a placebo for UPPP, a realistic placebo for UPPP, or to double-blind UPPP. Not sure anyone will figure that one out. So don't hold your breath waiting for a double-blinded placebo-controlled UPP trial. So those are 5 levels of evidence. Those are 5 studies, actually 6 because I showed 2 in level 2, of UPP studies trying to address questions in our field about safety of the procedure, about outcomes of the treatment. Now, that's just 5 studies. To really get answers on how we should move forward, we want to be a little broader thinking than that. So we do these evidence reviews and grading. The pro of these is you synthesize multiple studies. The con is it depends on what makes it to the literature, what's published there, and there's a big risk for misinterpretation. An example of that is if you only look at level 1 studies for UPPP, you're not going to find any, or you're going to find very, very few. And if you draw the conclusion, based on very few studies, that there's insufficient data to say that UPPP is sufficient because there's so few studies, some will interpret that to say you shouldn't be doing UPPP. And that conclusion gets drawn because you ignored all the level 2, 3, and all the 2, 3, 4, and 5 studies, where there's actually a robust literature that consistently shows that UPPP has a beneficial effect. It doesn't cure sleep apnea, but has a beneficial effect. That's the con of evidence reviews, and that happens rampantly. It happens today. Recent AHRQ review of diagnosis and treatment of sleep apnea concludes there's insufficient data to say anything about surgery, because their criteria to make it into their review was to restrict to studies that didn't exist. The solutions to that is cast a wide net to find published data and get consensus among evidence reviewers that the interpretation is consistent among people who have different views of the field. So this was a systematic review and evidence grading that otolaryngology resident research fellow did with me. We reviewed all the level 1 through 3 studies rather than just the level 1 studies of sleep surgery. We looked at clinical outcomes, not just apnea hypopnea index. And I'm focusing on the subset that's just site-specific surgery. There's about 4,000 abstracts reviewed, as opposed to the AHRQ review or the American Academy of Sleep Medicine review, where there was less than 100 abstracts reviewed and only 10 to 20 papers reviewed. Here's the upshot of looking at site-specific surgeries. Predominantly, this is UPPP. There were 2 papers on mortality that met criteria. The results were mixed, meaning one showed UPPP was superior to no treatment. The other one, statistically, you couldn't say it was superior to no treatment. There was 2 looking at cardiovascular disease. Both said that surgery was superior to no treatment. There was 1 paper looking at automobile accidents. Surgery was dramatically superior to no treatment. Vigilance and response times, like performance measures, 1 paper, surgery, superior, but there was just 1 small study. Quality of life and health status, surgery was equivalent to no treatment. And I had an explanation for that I don't remember right now. Oh, they used instruments that were not sleep apnea specific. The instruments are not sensitive in these 2 studies. We're not sensitive to pick up the quality of life changes that you'd expect to see with treatment for sleep apnea. Unfortunate. But high-level studies do indicate that site-specific airway surgery improves many clinical outcomes. We also looked at papers that compared surgery, predominantly UPPP, to CPAP. There's 2 studies that looked at mortality. Both of them favored surgery over CPAP. One of them was the study that I presented. In both these studies, CPAP was not necessarily CPAP users, but people who had received a CPAP. So it's not to say we should do surgery instead of CPAP, but I think we should do surgery instead of nothing. Cardiovascular disease, surgery was better than CPAP for the same reason. A number of the patients who are on CPAP presumably weren't using it. Quality of life, in both these studies, which did have sleep-specific measures, they were equivalent. Surgery was equal to CPAP in improving quality of life, and both improved quality of life. Likewise with symptoms. So site-specific airway surgery is equivalent or better than CPAP on measured outcomes when we're talking about all-comer CPAP patients. So this evidence review filled a gap there's still a gap with this evidence review. We had evidence levels 2 and 3. We looked at clinical outcomes, and we looked at multi-level surgery. So those are gaps that are filled. I didn't show you the multi-level data. I hasten to point out the UP is only a partial treatment for many patients with sleep apnea. It gets more difficult to review the evidence for multi-level surgery because it's very heterogeneous. In fact, the American Academy of Sleep Medicine, when they did their review of surgery, said, we're not going to look at multi-level surgery. It's too complicated, it's too much of a mess, so we're just going to put it aside. Unfortunately, people who are using that guideline to draw conclusions ignore the fact that they explicitly ignored a big part of our literature. And that's a misinterpretation problem that I mentioned earlier. All right, I'm going to conclude with cost-effectiveness analysis. The pro of cost-effectiveness analyses are that they integrate cost and outcomes, because both are important considerations in a treatment decision. And together, these have major policy implications. The con of cost-effectiveness analysis is there's a ton of assumptions that go into doing this type of analysis. Also, it requires sufficient cost and outcomes data. If there's not sufficient data, you can't do the analysis, the published data. The solutions for the assumptions problem, the best thing we can do is a multi-way sensitivity analysis, which means, and use conservative assumptions. Use conservative assumptions and cast a wide boundary around those and test at each extreme of the boundary. If along your wide boundary you still see a cost-effective result, then you can make the conclusion that it's cost-effective with varying that assumption. The problem is most cost-effectiveness analysis vary one assumption at a time when there's hundreds of assumptions that go in. So better than that is to do a multi-way sensitivity analysis where you vary multiple assumptions all at the same time, and that's done with a modeling technique I'm going to describe here in a second. So our research question with this analysis was, is UPPP cost-effective compared to no treatment, and is it cost-effective compared to partial CPAP use, defined as 1 to 6 hours per night? That definition was based on what's in the literature for survival data on partial CPAP use. So cost-effectiveness compares treatment options on cost difference, how much the difference in cost between the treatments, and effectiveness difference, and makes a ratio of those 2. That's the cost-effectiveness ratio, or incremental cost-effectiveness ratio, ICER, for people who are familiar with these methodologies. So for effectiveness, we want to measure quality of life and quantity of life. You want patients to live longer, and you want them to live better while they're living longer. That's measured with a measure called quality adjusted life years, QALYs. Here's examples of treatments and their cost effectiveness. Lipid-lowering medications, based on pretty extensive analysis, has been published at costs about $15,000 to have an improvement in one quality-adjusted life year, meaning you live 1 year longer at 100% quality of life, however you want to define that. It's based on various measures. Cochlear implant bilateral is about $62,000 per quality-adjusted life years. These are both considered cost-effective treatments. The reason they're considered cost-effective treatments is you just got to set a benchmark for how much money you're willing to pay to get a quality-adjusted life year. And that benchmark in today's world is about $100,000. And it's based on the fact that an implantable defibrillator for a patient with an ejection fraction less than 35% costs about $100,000 per quality-adjusted life year. And that's just been deemed by policymakers as being a worthwhile treatment, but the cutoff for what we're willing to pay. So anything less than that you would consider cost-effective based on that admittedly somewhat arbitrary benchmark. So our hypothesis is that surgery, and specifically UPPP, is cost-effective below the $100,000 per quality-adjusted life year benchmark compared to no treatment and compared to partial CPAP use. We took a pair perspective, looked at a 10-year time horizon, and did Markov modeling. Since I'm short on time, I'm going to blast through some of these methods. The data were from national databases based on inpatient costs, cost of complications, and cost of car crashes. We did not include indirect costs, which is a big issue with most cost-effectiveness analyses, important in real-life decision-making, but really difficult to model. The effectiveness data were all based on published literature. We use the 95% confidence intervals as our boundaries for variances that we're going to test with sensitivity analysis. That's a very conservative, broad net to use 95% confidence intervals. For the quality of life, we used 2 validated measures that exist in the literature. However, you can't just use these measures by themselves. You need actually a utility version of these measures. So we actually created a utility version of these measures. What a utility version of these measures means is you convert the score from whatever the range is on the normal instrument to a 0 to 1 score. And you can't just divide by a number to make it a 0 to 1 score. There's a whole validation process. So we're presenting data for the SNOR 25 conversion to a utility instrument at the sleep meeting coming up in the next couple weeks. We haven't completed the FOSC version, but the analysis I'm going to show you is based on a preliminary FOSC utility instrument. That's quality of life, necessary to do the quality adjusted life years. The quantity of life was based on survival studies. We use Markov modeling that allows us to synthesize data across studies, use multi-dimensional sensitivity analysis, and we did, it's creating a computer model with all the assumptions built in, and then you can vary the assumptions and look at the outcomes. So you can vary the assumptions to go to all one extreme, all the other extreme, one at one extreme, one at another extreme, all different combinations. We did 50,000 iterations to have a whole bunch of different combinations of the assumptions. And what you do is you see with each assumption, with each combination of assumptions, what's the outcome? Is it cost effective? So I'm going to blast through Markov modeling and show you the results. Here was the cost of UPPP, $10,000 plus. No treatment costs $4,000. How does no treatment cost $4,000? Because they're more likely to have a car accident. They're likely to have other healthcare costs that are included in this analysis. The difference, though, is UP costs $6,400 plus more than no treatment. However, you gain 1.1 quality adjusted life years when you had a UPP versus no treatment. This is based on published data that we then converted the instrument, how we measured it, to have not just length of life, but also quality of life. 1.1 quality adjusted life years. With Markov modeling, it turns out that the median value, or the median cost per quality adjusted life year for UPP compared to no treatment was $8,400. The 95% confidence interval for the range of dollars per quality adjusted life year was $2,000 to $22,000. And in greater than 99% of the iterations of the assumptions varied, UPP was more effective than no treatment. And in greater than it was actually much greater than 99% of the iterations, it was cost effective under the $100,000 benchmark. And here's the data that shows the Markov modeling. On the x-axis here is number of quality adjusted life years gained. Incremental effectiveness in UPP compared to no treatment. So 0.3, 1.3, 2.3, 3.3. On the y-axis is cost, incremental cost of UPP over no treatment. This dotted line, anything to the right of the dotted line means that UPP is cost effective above and beyond no treatment. And you can see the modeling here shows that almost every single result of the modeling was on the right of that. Some, it was very cost effective. Some, it was barely cost effective. But in all cases, it was more cost effective. How about compared to partial CPAP? UPPP costs the same amount. Partial CPAP actually costs $16,000 plus. Why does it cost so much? Well, you have the treatment costs of the CPAP and the sleep testing and so forth. But if they're not using it, they also have the bad outcomes and the costs of the bad outcomes. So it turns out that UPPP is less expensive than partial CPAP use. And it turns out you get better duration and quality of life. So you pay less and you get better outcome. That's called the dominant condition. You don't even calculate $1 per quality adjusted life year. It's dominant. It's less cost and better quality of life. Now, I hasten to point out this is partial CPAP use. Doesn't mean it's better than CPAP. It means it's better than not using your CPAP or only using your CPAP part of the time. Less cost, more qualities. And in the Markov modeling, varying all the assumptions on costs, outcomes, survival, quality of life, blah, 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 all simultaneously, UP was more effective than partial CPAP use in 90% of the iterations. And it was cost effective under the $100,000 benchmark in 87% of the iterations. Here's the mapping of that. So to put this in context, UPPP versus no treatment is highly cost effective based on the existing benchmarks that exist in our society by policymakers. And UPPP compared to partial CPAP use is dominant. That means it's no-brainer that it's worthwhile. There are major limitations to any cost effectiveness analysis. Here's highlighting some. It was a 10-year time horizon, but sleep apnea is a chronic condition. It lasts longer than 10 years. So a longer horizon would have required us to extend beyond the existing survival data and increases the risk of error. So we didn't do that, but as longer survival data come out, that allows us to have a longer time horizon. I actually think it'll improve our outcomes, our cost effectiveness for surgery, because the curve going out to 10 plus years right now still shows consistently that UP slows the progression of death compared to no treatment. There's geographic variations of costs. And so in some places it might be cost effective, in other places less cost effective, just depending on the costs. We did not include cardiovascular disease, which is an important morbidity related to sleep apnea. We didn't include it because the data, published data, were not robust enough to include it. We have compared UPPP versus full CPAP, but I didn't present those data. And there's still a lot more analysis needs to be done to do that analysis. We didn't include other surgery, and that needs to be done in the future also, once the data are available. The conclusions for this cost effectiveness analysis is that surgery is cost effective compared to no treatment, and surgery is likely cost effective compared to suboptimal CPAP use. And the reason I say likely is because in 90% of the models it was, but in 10% it wasn't. So let's come back to these key questions on UPPP outcomes. This operation that doesn't work, doc, I heard it doesn't work. Does it work? Yes, it works for improving a variety of clinical outcomes related to sleep apnea morbidity, but it's not a cure. So it doesn't work if you're looking for cure. It does work if you're looking for improvement. Is it safe? I would say yes, it's safe. The risk of serious complications is actually very low. How does it compare? It compares well. Certainly compares well to no treatment, and I'd argue it compares well, even on a cost effectiveness basis, to partial CPAP use. So is it cost effective? Yes. What I've tried to do here over the last hour and 10 minutes or so, is illustrate for you what UPPP is and show you its potential value in the treatment of obstructive sleep apnea. And what we need to do is generalize from this to a whole array of surgical treatments for sleep apnea, so we're only just scratching the surface. Thank you for your attention. Sorry to take in here to the very bitter end of 7:30, so thanks again for your attention. Maybe if there's questions, I can take a couple minutes. Yeah? Thank you. Yeah, great question. I'm not aware of any published data on UPP or surgery looking at blood pressure outcomes. Those studies. So to summarize, the question was, there's 2 articles published in the current issue of JAMA looking at incident hypertension, the incidence of hypertension in sleep apnea, and the effect of CPAP in reducing incident hypertension. Those are novel because the previous blood pressure studies looking at sleep apnea were not incident hypertension, but people with existing hypertension did CPAP lower the blood pressure. And the data were inconsistent between the 2 studies. One study suggested that CPAP does reduce incident hypertension. The other study, on the surface, looked like it didn't. And one key explanation for why it didn't was because it was a very limited subgroup that was studied in the second study. I'm going to take a little digression from your question and explain that. The first study was a cohort study. It was large. It had a wide array of patients. It was very generalizable. They just observed patients who got CPAP compared to the patients who didn't get CPAP. The second study was a randomized trial. You can't just do a randomized trial and prescribe CPAP to some and not to others because it's known that CPAP helps sleep apnea. There's a subgroup of patients where it's not clear that CPAP helps sleep apnea, and those are patients who are not sleepy. Turns out those patients don't suffer the same morbidities as patients who are sleepy. So they did a really, really well done trial, randomized trial of CPAP in patients who are not sleepy. They also didn't have hypertension, most of them. Their outcome was incident hypertension. Half of them already had hypertension. One of their outcomes, their main outcome, was incident hypertension. You can't get incident new hypertension if you already have hypertension. So that randomized trial was inherently constrained in such a way that it couldn't find this result. And that was a large part of what our editorial, I was asked to write an editorial about this with a sleep medicine colleague, was about, is the methodologies are critical in interpreting the results, because if you don't interpret them, you come up with 2 vastly different interpretations. And our interpretation of it was CPAP has the potential to reduce incident hypertension. That's profound. In spite of a randomized trial suggesting it doesn't. And what we draw from that is that in certain subgroups it might not, and we need more data. Now, the role of surgery in that. You may have noticed one line in there that said this needs to be investigated for other treatments as well, because there's no data for surgery that's published. I can tell you the sleep study that I showed, the level 4 study, where we looked at quality of life outcomes and symptoms. We also measured blood pressure in a subset of those patients. And I'm excited to present those data because it's remarkably favorable. It's not a big reduction in blood pressure, but it's a significant reduction in blood pressure, as good as or better than CPAP. So I think surgery is going to have an important role in managing cardiovascular morbidity related to sleep apnea. There's a little bit of data out there, and we need to produce more data. These are hard data to come by. So I do think surgery will have a role there, but we're not in a position to make that claim yet, and that's reflected in the editorial of just saying this is a question that needs to be answered. The big challenge with CPAP is a lot of patients don't wear it full time. In a trial, they're more likely to.
I just say wrapping up the formal session. Hopefully we have other questions. Very impressed. All of us are very careful planning.
Thank you, Dr. Jarrett.